Now, so here, ideally, I like to make sure our left side is clear. I mean, I don't know for a fact if it's clear or not. Pull that wire. So if this.
Yeah, and I don't know if there's a stone there or what. Okay, when it goes up, you have to stop. Stop there. Stop. Now you advance the catheter slowly. Wire opposite. So let me just do this for a second, because I think we need to get into the left duct to make sure there's no stone in there. So what you do is, when her wire is up in the duct, advance wire. Okay, now I'm going to gently push forward. Yeah, she's pulling me and I'm advancing, just like a cannulation. Wire, come back. Advance wire. Keep advancing, push. Okay, let me go and more. There you go. Okay, wait, stop. It's not going. Okay. So I'm going to pull back for a second, and then you try and go in now. I'm just trying to straighten the wire. Advance the wire. Advance wire. It hits. Okay, pull me in slowly. So you pull slowly wire. It keeps buckling up there. Yeah, it's okay. Balloon up here. That's right side. So balloon up. 15 is good. And exchange.
We are in the right duct.
Yeah, that's right. But I want to see left as well. Exchange. Push wire.
Yeah. Any other thoughts from the room?
Okay, down. So here, ideally, I would like to make sure our left side is clear. I mean, I don't know for a fact if it's clear or not. Pull back wire. So if this wire doesn't work, we may switch to an angled wire for the left system, because we're getting this. There you go. Push more.
So, Mustafa, what do you think? What's the pathology this patient is suffering from?
Well, we found stones. I don't know if there's more than anything else, anything than that, or. But here, I just worry that there are stones in the left hepatic duct. So we could either try and get an angled wire up. Once we get a wire up, then we can. I don't think this is cholangio. I mean, that could be the other possibility. Could there be a stricture? Balloon. But I think it's an angle issue. Balloon up for a second. 250. Yeah. Then try wires. So pull back. Pull back. And try wire now.
Endoscopy and Colonoscopy.
Right here, keep back. Try wire now. Okay, stop. If it advance now.
That's what right system you've been able to
angle wire. Can we get an angled long? Angled long wire. एक सीन अभी तो करें advance. नहीं एक सीन advance करें. Keep advancing. Keep pushing. But it's still just not wanting to. Well, any other thoughts from the room? Yes, sir.
Yes, sir.
We were just wondering.
Wire exchange. Yeah, go ahead.
No, it's just the change of the angles.
Sorry, I didn't hear you. I can't hear you, doctor. Yes. Sometimes it's just an angulated duct and it ends up being nothing. But we're going to try a different wire to begin with. I think sometimes an angled wire will take you.
Still getting resistance.
Other times you have to use a different device or a tone. So that may be different now. Advanced wire.
And Colonoscopy view, please.
Okay, pull me in. The alternative would be to do Endoscopy and see what's going on up in there. Balloon down, sorry, balloon is up. I didn't realize. Balloon down.
Control room, please. Endoscopic and Colonoscopy view, please. Yes, now it's better.
No. Balloon down, balloon deflate. Okay. Try wire.
So, Dr. Musa, have you been able to go to the left ductal system deep with your wire, or you still
No,
trying to?
that's what we're struggle is. Right system with we've been able to go,
Yeah,
but the
right
left,
system you have been able to go
yeah,
multiple
it
times.
makes me wonder if there's a stone. It could be a bit, obviously something more
Yeah,
concerning, like a
there appears
stricture.
to be some.
Yeah, there we go.
Yeah, this shadow.
So this hopefully will be better. This is now the angled wire. जाती है और मैं आता हूँ हाँ वो मुझे बकल कर जाती है मैं आता हूँ pull me in, pull
4-1.
me in.
Do you want?
So we're trying to pull me in, but hopefully in that process the wire doesn't get buckled. So we're just gently trying to. The principle here is that I can only advance over a stiff part of the wire. So that's why we advance the wire in deeper. Now the balloon is taking that turn. Up now we're going to pull back the wire and try and get deeper into that left system.
Are you convinced that this was a papilla or was it a fishless opening? I think it's a papilla. I think
Still getting resistance.
Fishless opening, maybe preparation.
We're injecting now again.
Me look like papilla, but I could be wrong, I guess. Look like what? Now that we know some different trajectory wires.
So will it be worth inflating the balloon and then giving a bit of flexion?
Yeah, we could certainly. We can inflate and just sweep, and sometimes with the inflated balloon, that'll propel the wire forward. So I might start with that. Yeah, so balloon up. Okay. See?
When do we stop here?
For beginners, I'm just gonna like sweep and see if that changes the trajectory of the wire, but it's still stuck there. But this also allows me to see if there's any sludge or debris that comes out, but nothing. Balloon down. So we're gonna now go up. He's gonna pull. I'm gonna take the turn again. And what Dr. Gas was saying is putting the balloon up here. Balloon up. थोड़ा fluoro head की तरफ करें. I need to.
So, Musa, based on the imaging which has been done previously prior to the procedure, there's a suggestion that there's a stone in the neck of the gallbladder. Can it be Mirisi?
Well, the thing is, we're in the what appears to be the left hepatic.
Yeah, that's right.
So this seems much higher than a Mirisi type of situation.
Yeah,
but I do wonder about a left
typical
hepatic
case.
duct. We'll inject for a second. Inject.
And lower down, are you convinced that this was a papilla or was it a fishless opening?
I think it was a papilla. I think if I had cut through a fishless opening, it would have been a perforation, to be honest. To me, it looked like papilla, but I could be wrong, I guess. Pull back wire. So now that we know some different trajectory of the wire, pull back wire.
We're just concerned that we would see a typical muscle appearance in the opening that you have created.
It's possible that it was. I mean, I'll be honest, there are a few things about this case that are not very clear cut to me. So we're going to just keep. The question is, when do we stop here? Or try a different strategy like spyglass? Pull back, balloon down.
Now, there's a suggestion from the room that Herbert trying spyglass.
Do we have a big enough orifice that we could put a Pete's colonoscope in there?
I know you're a fan of putting Pete's colonoscope in CVD. You done 2 cases.
Okay, wires come out completely. Let me look. Spy. What do we have? IMAX, spy, kuch hai? Ek second. Can I try the wire for a minute? Jitni देर में setup करते हैं, we'll just try the wire again. So pull back wire. Advance wire. See if you can get into that again. इस तरह पहले wire pull. Try again. Good. Let me pull back. Good. It's a very dilated duct there.
So Dr. Mustafa is switching to the other
Sure.
room while you're trying to...
Yeah, we're just getting ready for the phalangeoscopy.
Great. Thank you.
Sure, thank you.
Excellent display.
Thank you.
Are they with us or there?
Yeah,
I think they are with us. Okay, can we present the case? Okay.
We have a 52-year-old female with history of epigastric pain for the last 2 weeks. Her liver function test showed a cholestatic picture with total bilirubin of 0.5 and alkaline phosphatase of 166. Ultrasound is suggestive of cholelithiasis with choledocholithiasis. There is a 0.5 centimeter stone reported on ultrasound.
Okay. So, hello everybody. So Bashir is gonna just demonstrate how to pass the scope from the esophagus into the stomach and from the stomach to the duodenum. So right now we are right at the G junction. So rotate downwards. The wheels face okay right there, looking at the fundus. Yes, but gently advance. No. You're pushing way too. Just gently stop there. And now the scope views are facing towards the patient. Right. Scope is at more like it was 180. Went down a little bit to the other side. We're gonna just rotate the scope, bring the scope up and rotate to the right. That will take you straight to the body, distal body, and then to the antrum of the stomach, okay? Just big wheel towards you a little bit. So now what happened there? You retroflex, right? Yes. What happened? Because you are pushing the scope there. So we're gonna pull the scope back and then change the direction. And then go in gently now. Okay, good. So we are going in the right direction now. Big wheel towards you a little bit. Okay, that's where the pylorus is, right? Okay, we'll keep going to the pylorus. So this is good movement. Like you are 2-3 centimeter still distal to the pylorus. Your scope, and you let that view of the pylorus go. So big wheel towards you. Big wheel towards you a little bit more, right there. Now gently go in through the pylorus. You see that how gently it went, and you stop. Okay. Now we know the lumen is right over there on the right side. We're looking at the medial wall. We will big wheel a little bit towards you. Big wheel a little bit towards you. There, you see that how it's guiding the scope through that. Okay. Big wheel a little bit further towards you. Gently advance. Now you're beyond the duodenal apex. Small wheel away from you. No, small wheel away. You can lock it here if you want to, just to maintain that position. Okay. Now, hold the scope. You are gonna hold. I'm just gonna guide you. Okay. So right now we're gonna rotate the scope this way, and that puts us in the short scope position. Now you are in good position right here. We know we are beyond the papilla, right? Okay. So what we'll do is big wheel a little bit away from you. Rotate the scope to the right a little bit. Okay, right there. Pull the scope back a little bit now. Big wheel a little bit away from you. A little bit away. We're going to pull the scope back. Yeah, you don't have to use the second hand to move the big wheel a little bit away from you. So we're coming back in there. We missed that. Yeah. rotate. It's right arm there above edge. So we just gotta find the patella, big wheel a little bit. So no need to panic here. Gentle movements, relax here, because you need to relax before you are able to find it. So big wheel a little bit away from you, little bit away from you. Rotate the scope to the right. Pull the scope back so we can look above that. Pull the scope back. Big wheel a little bit away from you. Away, away. Gentle, gentle, not too much. So right there, okay? So now it's still a little bit to the right? So don't move too much. Small wheel away from you. Rotate the scope this way. You see that? You have to turn this way is not giving you a good approach. Rotating to the right is giving you much better approach, even though your back is towards the patient, which is fine. Actually, that stabilizes you much better. Okay, big wheel a little bit away from you. Little bit away from you. Okay, I'm gonna pull the scope back a little bit right there. You see how the papilla, few folds there. This is a good direction right there. And I think we got it. So when you are moving, the scope needs to move with it, okay? Just you moving and scope not moving does not make any sense, okay? Good, right there. So we'll sit there now, and we'll go ahead and do the cannulation. Get that?
So, Bashar, what we would like to see is that you're actually communicating with Ahad as well, okay? So loud, I think.
Yeah. Mustafa, okay, we can see you are back with us now.
Oh, good. So
we have the colonoscopy.
Yes, and you can see that we have done some EHL, because on the cholangioscopy you can see intraductal stone material, and in the distal, sort of in the papillary area also. So we may have done what we needed to do, but I'm going to clean this up. So at a minimum, there was a stone in the main duct. I want to get above this to see what's on. And you can see the debris coming out on the end of view. The question is, can we get past? Oh, so now we're like all the way down into what looks like maybe the cystic duct. So maybe what we had was extrinsic compression from the cystic. So Miritsis, as Dr. Gah said, and then the question becomes, if this was cystic, then where is the main duct?
Sir, we're just going to ask the team to make us see through the monitor. I think they're doing that right now.
Okay, and in the meantime, I'm just looking for my ductal anatomy here, because it's a big duct. So I think this is the cystic main duct bifurcation, and this here, I have to decide figure out what duct we're in right now. So earlier, I think we had a stone in the cystic that we did EHL on, and this, based on the floor images, now looks like the bifurcation, and you can see the branching of the ducts. So now the question will we be able to identify the left hepatic, because this looks like right side perhaps. So I'm going to just try and explore the other branch, which is this way. So this is all right. So that means that I'm getting deeper into the right system here. So for left, I have to come back and look more to the screen left. This is still right. I think this is the turn we were at with our wire. These ducts look pretty clear to me. What we could do, we have a couple of choices. So we've taken a pretty angulated turn into what I think is the left, but what we can do is inject contrast here to confirm that we're looking at true left versus right end here, which we can get fooled too. I don't know if there are any thoughts from the room. It's possible that we're in right end here, actually. But all this looks pretty good to me. So the only question will be those ducts that on the floor look more on the towards the spine, between the spyglass and the spine. If I can access those ducts. I just look at it, I think. Why are they doing it? Angle wiring. Why?
Where was the stone that we?
I think that might have been in the cystic.
In the cystic.
Yeah, what we did EHR. Left, right.
You call?
I mean, the other consideration here would be to stop for the day and come back.
What is our?
Musfa, can we
Yes.
switch over to the other room?
Yes, of course. Yeah. कितना और करना है इसको आज? इस केस को?
Okay, Nadeem, we are back with you. Dr. Khalid,
G.
we are back with you.
Okay.
So can we have a look at
Can
this
we
view?
have an endoscopy view?
Yeah.
Okay. So just to release the elevator just a little bit, not too much, just a little bit to stabilize yourself. Small wheel towards you now, little bit, and big wheel towards you at the same time. No, you went down, you lost motion. You see that? Okay, so come back and try again towards the top. Pull the just a little bit. Right there is good. Right there is perfect. Okay, stay there and gently advance the tome just a little bit without pushing. Okay, small, yeah, good. Small wheel a little bit away from you. There you Flora now. Floro de dena beta. Okay,
advance
go. Keep going gently. Keep the fluoro on. Good. Chalo. Now follow that wire. Good. Keep going. Now gently moving. You're in the bile duct, in the direction of the bile duct. Good. Let's go ahead and inject. Inject karo beta. Okay. Inject karo. Fluoro. Okay. That's good. Okay, keep pulling back. I think there may be a small stone there. Keep coming back. Yeah, right there is. It's kind of a linear stone. Okay, that's good injection. Let's do a sphincterotomy. Okay. Chalo, sphincterotomy aap karwa dein. Okay.
So let's just speak to your team and see what you want to do next. Do a plan?
Don't touch the paddle until you tell us the plan.
Remember the position. We don't want to lose our position. Okay, we don't want to lose the position. So we've lost the position. Good man. So stay in the good position. Adjust. That's it. Good. Well done. Okay. Now identify the folds that you're going to cut to. So you want to visualize the ampullary complex a bit more. Okay. So you don't need to do a lot of movements. Big wheel away from you.
Big wheel away. Gentle way away. Gentle away. Okay. It's okay. No need to panic.
Yep.
Okay. Just relax. Big wheel away. Pull the scope back a little bit. Pull the scope back. Okay.
That's it.
Pull the scope back a little bit more and big wheel further away from you. And release the elevator. You're putting a lot of pressure on the elevator. You see that?
Good.
That's what was the problem. Your elevator was lifted way too high. Okay, and that was putting pressure and distorting the papilla. Okay, so gotta be able to identify the problem to fix it. Okay, this is not bad position. We can go with that.
So remember, you have to cut in the direction of the bile duct. You don't move away from it. Okay, so you continuously will have to adjust yourself. Cut in this direction, not in this direction. Okay.
So both the wire a little bit. Okay. Now grab the scope, not the tone. No. Not the tone. Scope. You're going to guide with the scope, okay? Big wheel towards you a little bit. Okay. Right there. Not too much. Go for it. Now cut it. Good. Keep going. It's a good direction. Keep going.
Good.
Keep going. Keep going. Good job. Keep going. Keep going. Keep going. Pull the scope back a little bit.
Scope. Yeah.
Okay. Small wheel towards you. Okay, big wheel towards you a little bit. Right there. Go for it. Okay, good. Pull the big wheel towards you. So you see that there is a cautery there because your contact is not good enough. So bow the tome a little bit, bow the wire a little bit. Okay, and now go gentle. Keep going.
Keep cutting. Keep cutting.
Pull the scope back a little bit. That's a lot of.
Yeah. Keep going.
Yeah, right
slow,
there.
Slow. Yeah. Keep going.
One. No. Yeah. One touch. One touch. That's it.
That's
one
it.
touch. That's it. That's it. That's it. That's good enough. Okay. Now take a look at it before you go any further. I think you have cut the sphincter completely, so you don't need to cut any more. So now you can exchange and we'll do the balloon. You see that how sphincter is cut inside, nicely it's completely cut. Okay.
Don't lose the wire.
Be careful with the wire. Both of you need to coordinate. Both the tech and you. But well, get the balloon and do the balloon sweep.
So what do you think about the size of the duct? What size balloon are you going to use?
How big? What's the caliber of the duct? What's the? No. How did you estimate that? What's the scope caliber?
1.3, 2.3.
Yes, 13.
1.3. Yeah. And what's the diameter of the duct based on that? Almost 8-9 millimeter.
The half size.
Yeah. Okay. A little bit bigger than half. So. Okay.
So remember again, don't lose your position.
Yeah. Small wheel away from
readjust
you.
yourself.
Small wheel away. Okay. Gently push the scope in.
That's it.
Right there.
Good.
Now you see that how it's stabilized? Okay.
So be careful. Yeah, good. That's it. Excellent.
Good job. Keep going.
Really.
We're just gonna go all the way to the hilum because it's just one stone. Go to the hilar area. It's a small stone, one stone, so we can go all the way up to the hilum, and then we'll just do a balloon sweep from there without injecting.
Stop.
Balloon up.
Yep. Okay.
We don't need a fluoro. Okay.
Yeah, just minimize.
Just do it.
Okay. So keep withdrawing until you feel the resistance. You don't need to do anything at this stage. Just keep withdrawing. Yeah, keep withdrawing.
Fluoro dikhana zara.
Keep withdrawing. Do you feel resistance? Yeah, keep going. Okay, then in that case, was the balloon up? Balloon over? Okay, let's go again. Then go back and again. So that was a 12 millimeter, was it? Okay, you may need to go to maybe, and then she's sedated, well sedated, so you can even go for 15.
Take it.
All the way to the top. That's fine. Okay. Inflate to 15, inject some contrast and extraction. Let's just do that. Okay. So, okay. Extraction. That's it. Just go on. Extract. Well done. Keep going. When you get the resistance, you can then hold it in between your fingers. Yes, good. And then gradually push the scope in and then clockwise rotation. Good. Very nice. Zoom down. Yeah, I think the stone is it out? Yeah, this is okay, big wheel. Okay. I'm just going to do a quick balloon sweep and just to confirm that's it. So, yeah, thank you. Let me just take over. Thank you. I think you got the stone already. Oh yeah, yeah, here you got the stone. Okay, screen कीजिएगा. Screen please. Okay, बाएं ऊपर रखिएगा please. Okay, stop screening please. Balloon up to 15 please. Balloon down. Screen कीजिएगा please. Okay, stop screening please. Inject some contrast. Yeah. Okay, stop injecting screen please. That's fine. Balloon up to 15 there. Yeah, that's fine. Now, inject a bit more. Okay, stop injecting there. Okay, stop screening there as well. Okay, balloon 15 पे. Balloon 12 पे लाइए please. Okay, screen please. That's it. Balloon down करें. Down again. Okay. So stop screening please. Screening please. Stop screening please. Screen again. Okay. Stop screening. Inject some contrast. Okay. Stop injecting. Screen please. Okay. Balloon up to 12 there please. Screen please. Screen करते रहें. That's it. 12 पे रखिएगा balloon को. That's fine. Keep screening please. Okay. Balloon down please. That's fine. That's okay. Let's just do one more time and then we're done. Screen कीजिएगा. Okay. Balloon up to 12 please. Stop screening please. 12 कीजिएगा. Okay. Balloon down. That's it. Thank you. All done. Yeah. Well done, Basha. Good. Well done. Just wanted to make sure that we haven't missed any stone, just for the sort of completion's sake. Good. Well done. हाँ जी, sign out कर लीजिए please. Correct. अच्छा, वोल्ट रोल कब देते हैं शुरू में? Have you given वोल्ट रोल? हम लोग before इसको अच्छा, जो प्री असेसमेंट दे इन रूम आने से पहले बोल दिया हो. जबरदस्त. मेहरबानी जी.